So, I want you to just take a second and think back to the last time you were at a doctor's office, right? And they hand you a medical consent form.
Oh, yeah, while you're usually sitting on that awful crinkly paper on the exam table.
Exactly. You're in a gown, freezing, holding this cold clipboard. And I mean, let's be honest, you probably just skim right to the bottom and sign your name.
Right, because it just feels like a mere formality, like a quick box to check before the actual medicine happens.
Yeah, it honestly feels a lot like mindlessly clicking I agree on those iTunes terms and conditions. You just kind of assume, well, a team of lawyers and doctors figured out the fine print, so your signature is just a green light.
But it's actually, well, the reality is completely different.
It really is. And that's what our deep dive is about today. We're digging into this big stack of medical guidelines, aesthetic practice standards, and psychological literature.
And what we found is that, especially in the high-stakes world of cosmetic and functional procedures, consent is definitely not just paperwork.
No, it's actually an incredibly complex psychological and legal minefield.
The modern approach we're exploring today is, frankly, miles away from clicking I agree on an app. It's much closer to, like, premarital counseling.
Premarital counseling, yeah, that's such a good way to put it. Because establishing true consent requires this deep, meaningful, and sometimes really difficult dialogue between the practitioner and the patient.
Exactly.
So our mission for this deep dive is to figure out, how do modern clinics construct a balanced, pressure-free consent process?
Yeah.
Like, how do they actually separate a true physical discomfort from cosmetic anxiety or even, relationship-driven pressure?
Well, to understand how clinics screen patients today, we kind of have to rewind a bit. We have to look at the legal earthquake that completely redefined what informed consent actually means in practice.
Right, because the ground completely shifted under the medical profession's feet over the last decade, didn't it?
It really did. So for a very long time, medical consent was governed by this legal precedent known as the Bolam Principle.
And what did that mean practically?
Basically, it meant a doctor's actions, including what specific risks they decided to tell you about, were judged by what a responsible body of medical men would do.
So if a group of surgeons just decided among themselves that, say, a 1% risk of a complication wasn't a big deal, they simply didn't have to tell you about it.
Exactly. The medical establishment basically held all the cards regarding what information you deserve to know. It was a highly paternalistic, doctor knows best model.
Wow. They just decided for you.
Right. But that entire paradigm was shattered in 2015. There was this landmark UK Supreme Court case, Montgomery versus Lanarkshire.
And that changed everything.
Oh, completely. The Supreme Court shifted the focus entirely away from what the doctors thought was important and placed the burden squarely on the patient's reality. So now, doctors must disclose any risks that are, quote, material to the individual patient.
Okay, but material in this context is highly subjective, right?
Very.
I mean, it means judging the risk based on what a reasonable person in that specific patient's position would want to know.
Right. Or what the doctor should reasonably know that specific patient would care about. The standard move from the medical community's consensus directly to your unique life circumstances.
Okay, I had to push back on the practicality of this, though. Doesn't that put kind of an impossible burden on doctors?
How do you mean?
Well, I mean, a busy surgeon might see a dozen people a day. How can they possibly know what matters to every single patient's internal life without spending, I don't know, hours and hours with them like a dedicated therapist?
So you're hitting on the exact tension that forced the initial medical consultation to evolve so drastically. Following that ruling, the General Medical Council, the GMC, issued a comprehensive new framework.
Saying like,
That consent is officially no longer a one-off event. It's not a signature on a clipboard anymore. It has to be an ongoing, meaningful dialogue tailored to your life. A doctor can only know what matters to you if they ask probing lifestyle questions.
let's actually ground this in a real example, because a tiny risk means entirely different things depending on, say, how you make a living.
Oh, absolutely.
Like, take a minor risk of nerve damage in the hand during a routine procedure. To someone working at a computer all day, a slight temporary numbness might be an acceptable risk to cure a nagging issue.
Right.
But to a professional concert pianist or, a neurosurgeon, that exact same 1% risk is a career-ending catastrophe.
Exactly. And the doctor has to know you are a pianist before they can ever obtain valid consent. If they don't ask about your career, your hobbies, or your daily life, they simply cannot properly evaluate whether a risk is material to you.
Wow. So the clinician has to deeply understand your specific reality. Which brings us to the massive challenge clinicians face today, especially in the world of cosmetic and highly sensitive functional procedures.
Because consent now requires this really intimate understanding. Doctors have this huge task of untangling why a patient is really sitting in their clinic.
Right, they have to separate a functional need from an external pressure.
Yeah, the consultation basically becomes a diagnostic tool for motivation. When a patient requests a highly sensitive procedure like a labiaplasty or treatments for GSM, the clinic has to figure out the root cause of the distress.
Well, let's unpack the physical side first.
Yeah.
Because we hear about conditions like GSM, genitourinary syndrome of menopause, right?
Yes.
As estrogen drops during menopause, it creates chronic, progressive anatomical changes. We're talking about tissue fragility, severe dryness, and urinary issues.
It causes real functional daily pain.
Right, that is a clear-cut physical issue.
Exactly. Another clear functional issue might be, say, a patient seeking a labiaplasty because they experience physical tearing or pain from everyday activities, like wearing tight clothing or cycling or horseback riding.
So the anatomy itself is actively causing physical distress, and the intervention is just aimed at restoring comfort and function.
Yes, exactly.
But how does a clinician pivot from treating that obvious physical distress to evaluating someone whose anatomy is entirely healthy, but they're just deeply unhappy with it? Because the cultural shifts driving people into clinics for aesthetic reasons are just profound right now.
They really are. The guidelines from the Royal Australian College of General Practitioners actually highlight how radically grooming habits have changed over just a single generation.
Oh, yeah. Extensive waxing and laser hair removal expose a lot more skin than in previous decades.
That, plus the mainstream prevalence of G-string underwear and incredibly tight, body-hugging activewear, suddenly anatomical details are much more visible on a daily basis.
Which breeds a new kind of hyper-awareness and self-consciousness.
Yeah, exactly.
And there's also the massive, unavoidable influence of pornography and heavily edited online media. Explicit images are heavily airbrushed due to aesthetic trends and content classification rules.
And that creates what the medical guidelines explicitly call a lack of knowledge of genital diversity.
Right. People are constantly consuming these heavily edited, uniform images online, and then they look at their own natural, varied anatomy and incorrectly conclude that they're somehow deformed or abnormal.
The psychological impact of that media consumption is profound. Patients actually bring idealized, filtered images into the clinic as their reference point for what is, quote, normal.
I mean, it feels like being a detective. The doctor is trying to figure out if someone is buying a sports car because they genuinely love driving and appreciate the mechanics,
Right.
or because their partner told them they need to look cooler, or because their neighbor just bought one and they feel inadequate.
That's a great analogy. As a clinician, if the motivation is keeping up with the neighbor, or in this case, matching an airbrushed internet image, surgery is never going to fix the underlying lack of confidence.
The dissatisfaction will just migrate to something else.
Exactly, but beyond societal pressure, the screening process also has to uncover much darker, more direct external pressures.
And this is where the psychosexual history check becomes so critical, right?
It's vital. Doctors use these initial consultations to screen for external coercion. They have to carefully construct questions to ensure the patient isn't being pressured by a romantic partner to change their body.
So they're actively screening for red flags indicating intimate partner violence, or even a history of sexual abuse.
Yes, they have to.
But how does a clinician even begin to uncover something so sensitive during a cosmetic consultation? I mean, if someone is being coerced by an abusive partner, they aren't likely to just volunteer that information on an intake form.
No, of course not. It requires immense tact. The clinician might ask questions about who initiated the idea for the consultation, how their partner feels about the procedure, or if they feel safe in their current relationships.
That makes sense.
Because a request for genital surgery can sometimes actually be a trauma response. It's a form of displacement where the patient is trying to regain control over their body after abuse.
Oh.
In those cases, the patient desperately needs specialized counseling and non-surgical care, not a scalpel. Performing surgery could actually deepen the trauma.
That is so heavy. So if a patient is pressured by a partner, the consent is completely invalid.
Absolutely.
And if they're in physical pain from GSM or cycling, treatment makes perfect sense. But that clarity vanishes completely when the pressure isn't coming from a partner and it isn't coming from physical pain, but is instead driven by a distorted internal mirror.
Right. Now we enter the psychological minefield of body dysmorphic disorder, or BDD. This condition is the exact reason the modern consent process has evolved into an absolutely critical safety net.
The statistical prevalence of BDD in these settings is actually staggering. Data shows that 26 to 40% of people with BDD actively pursue cosmetic surgery.
Yes.
And in some specific cosmetic patient populations, up to 50% might suffer from it. We're not talking about a rare edge case here. This is a massive portion of the waiting room.
It is. And BDD is a severe psychiatric condition. It's characterized by a distressing, obsessive preoccupation with a perceived physical defect.
But to the outside world, the doctor and the patient's friends, this defect is either completely unobservable or incredibly minor.
Right. Exactly. But to the patient's brain, it is glaring, grotesque, and just all-consuming.
And beyond the obvious signs like, excessive mirror checking, there's a fascinating term in psychodermatology that frequently pops up in the sources. Charismaphobia.
Ah, yes. Charismaphobia is the persistent, overwhelming fear of being or becoming unattractive.
Just the fear of it.
Right. It drives patients to constantly seek reassurance from others, engage in heavy, time-consuming grooming rituals, or jump from dermatologist to plastic surgeon trying to fix these invisible flaws. Their self-worth is entirely tethered to a fading or imagined aesthetic ideal.
Here's the central puzzle, though. Why doesn't the surgery just fix the obsession?
What do you mean?
Like, if a patient hates the shape of their nose or their labia, and a world-class surgeon perfectly alters it to their exact stated specification, shouldn't that cure the dysmorphia? I mean, they got exactly what they asked for.
Logically, you would think the scalpel would solve the problem, but psychologically it almost never works because BDD is not a problem with the anatomy.
It's a brain issue.
Exactly. It is a problem with the brain's processing of self-image. The brain is effectively glitching in how it perceives the physical self. If a surgeon operates on a patient with BDD, even with a technically flawless result, the patient rarely feels relief.
Because the brain just finds a new target to fixate on.
The focus simply shifts. They might suddenly become obsessed with a new imperfection on a completely different part of their body. Or, just as dangerously, they feel the surgeon didn't go far enough.
Which leads to a tragic cycle of constant revisions.
Yes, where the patient demands more and more extreme interventions, feeling increasing despair because the internal distress was never actually addressed. Operating on a patient with BDD is often actively harmful. It exacerbates their psychiatric condition.
Okay, let me play devil's advocate for a moment here.
Sure.
Because everyone has insecurities. We all look in the mirror under bad lighting and pull at our skin, or worry about aging, or feel a bit self-conscious about sensitive areas. Where is the line between normal, healthy aesthetic anxiety, the kind that makes you buy a nice anti-aging cream, and a psychiatric red flag that requires a doctor to halt a procedure?
Finding that line is arguably the hardest part of a cosmetic clinician's job, but the boundary is drawn at functional impairment.
Functional impairment.
Right. A normal insecurity might dictate the type of swimsuit you buy or make you feel a bit shy at a pool party, but BDD dictates how you live your entire life.
Oh, I see. It's about the magnitude of the disruption to daily functioning.
Exactly. We have to ask, is the patient spending 3 hours every single day obsessing over this flaw? Are they avoiding social interactions entirely? Have they stopped going to work because they feel too hideous?
Are they demanding a 100% perfect, mathematically unattainable result?
Yes. When the anxiety restricts their existence and their expectations completely detach from surgical reality, the clinician must step in.
Well, the strategy for how clinicians are advised to handle these red flags surprised me. Dermatologists and surgeons are strongly advised not to use the terms BDD or dysmorphia when they first address this with the patient.
It does seem counterintuitive to avoid the medical term for what you're seeing, but it's a very deliberate clinical strategy.
How so?
Well, if a patient comes in desperately asking for a physical fix and the doctor immediately responds with, "I think you have a psychiatric disorder called body dysmorphia," the patient is going to feel incredibly dismissed.
They feel labeled and judged.
Exactly. They might spiral into shame or go home and fall down a terrifying internet rabbit hole of psychiatric diagnoses, and ultimately they will just leave and find a less scrupulous doctor who will take their money and do the surgery.
So, to prevent that outcome, the guidelines suggest validating the patient's distress without confirming the perceived physical defect.
Yes. The doctor focuses entirely on the symptoms of anxiety. They might say, "I can see how much distress and anxiety this area is causing you, but in my professional opinion, I don't believe surgery will actually give you the emotional relief you're looking for.
The goal is to gently steer the patient towards psychological support, to address the internal pain, rather than attacking their reality with a psychiatric label.
That's exactly it.
So, knowing these immense psychological risks, the external pressures from social media, the potential for intimate partner coercion, the hidden prevalence of BDD, how do clinics practically construct a daily process that protects the patient?
This brings us to the structural safeguards. Because human psychology is so vulnerable in these settings, the GMC and various aesthetic medical guidelines have mandated an architecture designed specifically to prevent rushed, pressured decisions.
And one of the most vital structural changes is the mandatory cooling off period. Typically, this is a strict 2-week window, right?
Yes, 2 weeks. You have the consultation, the doctor details all the information, the material risks, the alternatives, and then you are sent home. You simply cannot book the surgery for the following day.
Which makes sense, because a clinic is a highly controlled, persuasive environment. You're talking to a confident expert in a white coat, you're looking at glossy before and after photos, and you might be feeling the adrenaline of finally taking action on an insecurity.
It is decidedly not a neutral place to make a permanent medical decision.
Right. The cooling off period breaks that spell. It forces you out of the clinical hype and places you back in your own living room, surrounded by your normal life, to truly reflect on whether this permanent alteration is what you actually want.
Another major safeguard protecting that decision-making process is the absolute ban on predatory marketing.
This was huge in the sources.
The GMC strictly prohibits irresponsible promotions that manufacture a false sense of urgency. Clinics cannot offer cosmetic procedures as a prize in a competition. They cannot offer buy one, get one free deals on dermal fillers.
And crucially, they can't use time-sensitive discounts, like offering 20% off if you book within the next 24 hours.
Right. Let's look at the mechanism behind why a 24-hour sale is so dangerous for medical consent. A ticking clock triggers a scarcity mindset. It spikes your adrenaline.
Suddenly, your brain's fear of missing out on a deal completely overrides your prefrontal cortex's ability to rationally weigh the long-term risk of a complication, like, necrosis or nerve damage.
The marketing tactic actively destroys your ability to give rational consent. It exploits human psychology for commercial gain, which is exactly why it's banned.
And furthermore, there's a strict rule regarding the non-delegation of consent. The actual operating surgeon must personally obtain the consent.
Yes. A clinic cannot have a slick, non-clinical sales consultant sit with you, hype up the potential results, take your credit card, and have you sign a waiver, leaving you to meet the actual surgeon for the first time on the operating table.
The person holding the scalpel must be the person who looked you in the eye, discussed the material risks specific to your lifestyle, and assessed your psychological readiness.
Finally, the guidelines heavily emphasize the continuous nature of consent. Consent is a continuous state of agreement, not a historical event bound by a signature on a piece of paper.
Meaning you can withdraw consent at any absolute moment, even mid-procedure.
Yes. If you're having a treatment under local anesthetic and suddenly feel overwhelmed, you can say stop, and the clinician must halt the procedure as soon as it is physically safe to do so. You are never locked in just because you signed a form 2 weeks ago.
I want to ask a philosophical question, though, regarding all of these regulations.
Okay, lay it on me.
With the mandatory cooling off periods, the psychological evaluations, the banning of discounts, is there a risk that this framework leans a bit too far into paternalism? I mean, does it feel like the medical establishment is gatekeeping an adult's fundamental right as a consumer to change their own body however they see fit?
It's a fair question. But if we pull back and look at the bigger picture, this framework isn't gatekeeping. It's pure consumer protection.
Because they're a consumer now, not just a patient.
Exactly. When you walk into a clinic for a voluntary cosmetic procedure, you're occupying a dual role. You're a patient, but you are also a consumer buying a service. Because the service is medical, the stakes are permanent.
Right.
These rules exist to protect vulnerable consumers from predatory commercial practices. They ensure that your choice is genuinely autonomous, rather than a fleeting impulse driven by a high-pressure sales tactic, partner coercion, or an untreated psychological condition.
We have covered incredible ground today.
Yeah.
I mean, we started with that familiar image of hastily signing a form on a clipboard, treating consent as an administrative hurdle.
Yeah.
But we've seen how modern medical consent has evolved into a robust, multi-layered psychological safety net.
The entire architecture, from untangling whether the pain is functional like GSM, to screening for external coercion, to gently identifying body dysmorphia without causing shame, to enforcing cooling off periods, is meticulously designed to separate true physical or psychological need from temporary, culturally induced anxiety.
And the ultimate goal of all these hurdles and deep conversations isn't to turn people away from procedures that could genuinely improve their lives, right?
No, not at all.
The goal is to guarantee that any intervention a clinic performs actually serves your true long-term well-being.
It's about ensuring the treatment fits the reality of the patient, not just the technical capability of the surgeon.
Before we wrap up this deep dive, I want to leave you with a thought that builds on everything we've just discussed about expectations, technology, and self-image.
Oh, this is an interesting angle.
Because technology is advancing at a breathtaking pace. Imagine we reach a point where virtual reality and AI filters allow you to try on a surgical outcome in real time, right in the clinic, with 100% accuracy. A perfect digital mirror showing you exactly what the scalpel will do.
Basically, a flawless preview of your future self.
Exactly. So if we get there, will that perfectly align expectations and finally cure cosmetic anxiety, because everyone knows exactly what they are buying? Or will it trigger an entirely new, deeply profound psychological crisis, where patients demand that a surgeon make their physical, breathing, flawed flesh perfectly match an impossible, digitally rendered avatar?
Wow. That tension between our physical reality and our digital expectations is definitely going to define the future of aesthetic medicine.
Something to ponder the next time you're faced with a terms and conditions box or a medical consent form. Because as we've learned today, making sure you are truly informed is never as simple as just signing your name.